We're going to have three keynoters that are going to be helping us framing the why, where we're going. I'm going to actually introduce all of them individually because after each one of them, we're going to have a chance to sort of have some more conversation. So we're going to start with Dr. T. Dr. T. Manuel is president and CEO of The Case Made, and she is going to kick us off, get us started. I'm going to give you one of these.
Do I need the microphone?
I'm going to give you an even better one.
Well, welcome everybody. I'm excited to be one of the folks kicking us off today. And I'm hoping to do a little bit of level setting so that we are living into the power of this moment. So I want to name actually the power of this moment because I think that it's easy to forget it or to misunderstand it. Some of us may have thought that we were coming to this conversation to talk about all the things that are wrong with our country or all the things that are wrong with our healthcare system or all the things that are challenges that we have to fix. And James, to your earlier comment about appreciative inquiry and the importance of that and coming from an asset-based perspective, not a perspective that focuses on deficits, I want to say the opportunity of this moment is to think through what is working and to leverage that forward. The public conversation, right, is so incredibly negative that folks have lost their faith in what we can do together. And so what I want to say to us is it's not our opportunity in this moment to be a wreck on a wreck. It's our opportunity to lift up a conversation that gives people a sense that something bigger and something better can happen. We are desperately in need of that, not only in the communities across the country that many of us serve, but also in rooms like this. And I got to tell you, there are a few sectors that have been, I think, part of the dismal science of repeating all the negative stuff. The healthcare sector is one of the places where we have just a lot of data about what's challenging, and we tend to recite that to each other over and over again. So I want to set the tone for this conversation by saying this is a moment of lifting us up. And I want to do that by just thinking about, for example, what's happened to our frontline workers in our health departments across the country. I was called last year to a national conference of the health departments all over the country. And one of the things that the conference leader said to me was, folks are really low. This last year and a half has been really tough. Morale is low. Folks are really not feeling connected to the public health missions that they went to school for and have invested in, right? All of the conversations about the vaccine and whether you take it and whether healthcare folks are really rocking in the direction they should be has really taken a toll on our workers. We really need you to come and come and have a different conversation with our folks. I want you to hear that, right, as practitioners in the space. But I also want you to think about the way that we should be telling that story a little differently. There was an interesting New York Times article about a year ago that said, what is happening in our country? The story that we would have told a decade ago or so about what happened around the vaccine is totally different. What would it look like if we told a story like this? The vaccines are a miraculous achievement, and they are not partisan. They were created with leadership and investments from American companies, developed under a Republican president and distributed under a Democratic one. Scientists have shattered all medical expectations for how quickly they could develop a vaccine and how well it worked. Now, they went on, but I would say, think about what has happened, right? How fast we were able to deliver vaccines all over this country. More than 2 years into the biggest vaccination campaign in the history, right, certainly of our country, maybe in the world. 700 million dosages of the vaccine have been delivered. And we did that in all 50 states, across all military bases and territories across the world. We did that in record time. We did that in all kind of extraordinary circumstances. I live in Florida where the convention centers were opened up, where you got a chance to stick your arm out the car, get your vaccine, and keep rolling without even turning the car off. I mean, think how extraordinary that is, that on a dime we were able to do that. Think how fast even that our government was able to work, right, on a number of levels, not just the CDC, but also I remember when the Congress, after much debate, on a Tuesday decided they finally approved a stimulus package for $600 or $1,200. They did that on Tuesday, and by Friday, those checks started hitting people's bank accounts. Think about how that destroys a narrative about how government is inefficient, it can't work very fast, and we can't deliver things very quickly. How did it happen that we were able to do that? How we have been able to pivot from working in offices to not just from working at home, but to the hybrid model that folks can actually participate, right? Even today, from all parts of the world, and in the room, in part because of, right, what happened that came out of that pandemic, that we discovered, actually, we really can get work done from all kinds of places and still have rooms like this where people are able to experience and grow and share. Think about mutual aid that happened all across this country, folks helping each other differently than they did before. And certainly in our space, health departments showing up in different ways than they ever have before. I got to tell you, I saw some of the best messaging come out of health departments than I've seen in decades, because there was a real willingness to think differently about how we get people organized to do the work. So I want to say, I know we also hit some rough patches. Not everybody was excited about, right, the vaccine, and not everybody was excited about wearing masks. And there are all been memes all over social media of folks who were not excited about doing that. But for the most part, right, we really did some extraordinary things. And imagine if that were the conversation and we enrolled people in a story of heroism about who we are and our capacity and what we could do. That kind of story excites and engages people about what's next. So what if this conversation we had today was about how we leverage that moving forward? I got to tell you, in California, I've been working over the last couple months with a group of housing and health leaders from all across the state who said during the pandemic, we had to work differently together. We had to create different opportunities to figure this out. And we did that. Now we're afraid that we're going to go back to business as usual, and we don't want to. So how do we leverage the moment to figure out how to keep what's working together, the innovations, the ingenuity, the ways in which we were able to bring down the sort of bureaucratic walls, the firewalls, right, that separate us as sectors, to work hand in hand together. And I think that really is the power of the moment that we're living in today. If you came here for that conversation, I'm here for it. Because I think that's the power of the moment, right? It's that we've been working in quite a moment that is quite not just ingenious, but where there's just kind of ingenuity about how we get things done and a willingness to work differently than we have before. And so the conversation is, how do we carry that into the next part of our work? I want to say just a couple things just before I turn it back to our facilitators to get us rolled into the participatory part of our agenda, that we have to do what I just talked about. We in this room have to do more to build up a sense of public will around the issues we're talking about. I started out by talking about just how heavy folks feel right now. The anxiousness, the polarization that people feel is heavy. And again, we don't want to be a wreck on a wreck, so our conversation has to change. The way that we lift people up and energize them has to change. From my vantage point, and I could be biased because it's a large part of what I do. From my vantage point, 99% of what we should do in this room today is about public and political will building. 1% of that are the technical challenges of what has to happen in the healthcare system and beyond. And that is because we have solutions, right? A part of the reason we're here is because there was a fantastic report a decade ago that said there were all these amazing things that we could do. And all of us nodded and said, yes, we can do that. And then we didn't walk it out in a way that folks could say, yes, we could do that. And we've struggled to get folks to lean forward on these issues. So 99% is, how do we get the consensus around what's working? How do we get people to lean into something that's bigger than the moment? That's the struggle that we have. And I feel like that's the energy of how we should start the day. I just want to say this public will building stuff is really important. I don't know, many of you recognize that, but today we should be celebrating the passage of the Voting Rights Act of 1964 on this day, 1965, many years ago. When I think about that, I'm inspired, and I'm also challenged by it. One, because of how the Voting Rights Act has taken such a beating over the last couple of years, and our voting rights have been, tempered. And I want to say that a part of the reason that we're challenged by that conversation, or the challenge of the voting rights issues today, is a part of because we never built the sort of public will behind it. About Voting Rights Act, like most of the things that have, like a lot of things, even what we experienced in the last year and a half, came about because there was some kind of major disruption, right? A part of the ingenuity we're seeing came about because the pandemic happened. We couldn't help but do things differently. You got to kind of move, right? So it moved us out of our inertia. The Voting Rights Act of 65 came out of riots and protests. at the time. It was passed only literally because of the civil unrest that was happening at the moment. So much of what functions as our action-forcing events are the things that are, right, the triggering events, the climate disasters, the civil unrest around George Floyd, the Fair Housing Act of 68 only passed literally in 68 because after the assassination of Dr. Martin Luther King. There were 107 cities that were literally on fire because folks were rioting. And the Congress said, we have to do something. What do? Well, let's pass this act. Like, let's offer this up, right, to get folks to stop. And so much of our forward progression and our movement is because something negative has happened that forces us into action. I want us to think about a couple things today. One, right, what does it take, right, if we have been in these kind of action-forcing events, to how do we sustain that movement, right? If those things will happen, disruptions will come. How do we sustain the movement forward that we get when those things happen? Number one. Two, how do we not require disaster to move us forward, right? We've got to get to a point where we're moving things forward simply because they're the right thing to do. And then three, this issue about public will building. Even when those things happen, how do we build the public will behind that so people understand that it's not just a temporary reaction to a triggering event? It's about the values that we hold as a people. We should all be having quality healthcare. We should all be living in communities that nurture our health. And that's the sensibility that we bring forward as a way of how we think about ourselves. So I know that there are a lot that we're going to talk about today. I have lots more that I would love to say about this topic in the context of what we're doing, but I feel like our opportunity to lean into that moment, to build a sense of public will, to get people energized about the power and possibility of this moment is super important. And I hope that you'll join me in that in our participatory conversations today.
Thank you. So we promised that you were going to have a chance to talk to one another, and we're going to get that started right now. So here's what we're going to ask you to do. We're going to ask you to self-select in this room into groups of 4 or 5, like in that ballpark. So you can turn your tables, your chairs around. You can turn to one another, whatever you got to do. Online, Fisher's going to send you into groups. So he'll send you into groups about the same size. What we are going to ask you to do is, first of all, introduce yourself. You're going to come back to this group a couple of times throughout this morning. So go ahead and get the introductions and do that piece. And then, given what Dr. T said, we want you to contemplate this question and share your thoughts. What's the one thing that if people got it, it would change things? Like, what's the one, like, as we think about like making the case and sort of framing how we're going to move forward, if there was one thing, given the expertise that you have, again, your professional expertise, your personal expertise, what's one thing that if people got it, you think would change things? Right? So introductions, and then what's the one thing, and if people got it, it would change things. And we're going to give you about 10 minutes or so in order to have that conversation. Right? Is the task clear? Yes. All right. See, good. By the way, I'm not going to ask any rhetorical questions. So I got responses to the question. That's awesome. All right. So we're going to check back in about 10 minutes. Thanks. I have to tell you, I'm a facilitator, so I am really anxious to hear what people said in their groups, and I'm going to exercise restraint. I am going to wait. We're going to wait till the end of all 3 of the speakers, so you will have a chance to check in after each one of the keynote speakers with one another, and then we're going to sort of hear from all of you at the end, even though I'm itching. I'm having a hard time, but I'm exercising restraint. I can do this. So that allows me to introduce our next keynoter. It is Anita Chandra. She is Vice President and Director of Social and Economic Wellbeing at RAND. Let's welcome Anita.
Great. Thanks, James. And I know we're itching to share back. We were having a good conversation up here with Dr. T and Dave, and I'm looking forward to hearing more from everyone else. I'm so appreciative of the way that this conversation has been set up today, and certainly Dr. T's comments about public will and political will and social will and how we take and seize this moment. I thought I would sort of frame up some additional thoughts for us to consider based on work that I and others have been doing at RAND, some reflections that I just had even in this conversation with Dr. T and Dave, and then hopefully might set up some of the rest of the conversations for the day. I'm struggling with essentially three questions that I ask us to think about and consider as we press forward in the discussions today. One is principally a question of what exactly we're aiming towards as a country. Now, there's a lot of conversations about the North Star in health, and excellent work certainly from this Population Health Roundtable. But if you asked, the average American walking down the street here in DC, what is it that we are aiming towards with respect to the health of our country, I think you'd get a very mixed bag. Some might say, well, I hear that we need to make sure that everybody has health insurance. Absolutely admirable. Others would say, I hear we spend a lot on medical or healthcare costs and we need to contain them. And maybe a few would say, I want to make sure that I don't live with chronic disease. But none of those kinds of narratives really speak to an actual health goal in terms of our potential as a nation in a way that can really land and stick for the long term. And I'll talk about that in a minute. A second question is, we're going to hear a lot about wonderful innovations and exciting bright spots, and we're going to keep this conversation positive, and I promise to do that. But with all candor, I think the question that we have to pose to ourselves in this conversation and online, many of whom are leaders in health and public health and the like, when we add up all the innovations, does it actually add up to real transformative change? Is anything that we're doing in the collective going to move one of those data points that we see around the room, or that all of you are incredibly well versed in? Whether it's moving the needle on diseases of despair, whether it's moving the needle on health and well-being, does it hold up fundamentally? And the third question is the extent to which we have been, and this is what's so great about we created this culture, we can recreate this culture. To what extent have we made the issues too small and too narrow? Because it has been the way that we publish in academia, it's the way that we can get our arms around our issues, because we're constantly in defense mode, because we're worried that we're going to be disinvested in public health, and I can certainly empathize with that, or we're worried about somebody moving the goalpost in broader conversations. Have we actually missed the boat in terms of a grander expectation for all of our work? And you can see it, we were just talking, in a lot of conversations that we're all a part of when we are sitting in rooms where we're discussing the health strategy in a particular county, or we're trying to figure out what was the causal direction of one variable to another. In many ways, we've missed the point. And to what extent have we lost the forest for the trees in the way that we've structured and organized, the way that we're thinking about whether it's health indicators, whether it's our health narrative, whether it's our health goals? And when I step back and look at those three questions, I'm incredibly worried, but also incredibly optimistic that if we actually take the time to answer and address those three questions, we will be in a very different space than we've been before. Dr. T is right. I study disasters, actually, as part of the work that I do, whether it's hurricanes, whether it's COVID, whether it's climate. And you can sort of set your watch to the kind of the crescendo and the fall. And as we talk about COVID and we look at the narrative on the other side of COVID, the worry is that we're not taking this moment, that the energy and the excitement that we've had to connect some dots, perhaps is dissipating? And that's a question that we're going to all have to think about going forward. To me, there are essentially three pillars of this conversation. One is fundamentally the narrative conversation. And sometimes people worry, oh, we're talking about hearts and minds, but I'm talking about a fundamental mindset shift in the country. And one of the things that has been exciting about the last couple of years is that we've had a real conversation and an opening for a more holistic discussion of health, a more holistic discussion of well-being, quality of life. What does it mean to thrive and flourish? Some of that's been happening in pockets of the work of those around the room, but a lot of that has been generated by community leaders taking the time and the moment to say, what are we doing fundamentally? The question is what are the narrative connections that we're actually making as a field? What is that storyline that's going to take us from where we were before the pandemic to where we are now? To what extent do we have a framework and a leadership that understands the way to talk about health that's not just simply about healthcare? So when we look at kind of our messaging, our narrative structures, whether it's at the community level or at the national level, how often do points about human potential get raised by mayors, by our president, by our secretaries across the street here? How often is that actually part of the health conversation? One of the things that I was challenged by over the last couple of years is we've talked a lot about social determinants of health, vital conditions. We've talked about creating cross-sector collaborations in health in particular. And yet when we had the crisis of the last few years, we had sectors pitted against each other. We had the traditional health sector pitted against the employment sector, the economic sector. If we were working on a narrative that was more coherent and cohesive, that should not happen again. What is the conversation that we have about healthcare? We were just talking here at the table about the wonder of the vaccines. I marvel at the vaccines, but isn't that quintessentially an American story of health? We were very good about shots in arms. We were very good about taking our medicine. But we were terrible in terms of the larger health conversation when we compare ourselves to other countries who were able to adopt public health messaging that was more holistic and cohesive. You can look to South Korea or other countries that had more effective response. So to what extent has that been an illustration of our problem? Now, we created this kind of narrative over many, many years. I have an economist friend at RAND. We have a lot of economists at RAND who cites the sort of start of RAND, which was around the end of World War II, as the origin story of how we got into this place of conflating health and healthcare. We tied healthcare to employers, which is not on its face a bad thing, but we created a narrative for the U.S. that tied health and healthcare in ways that you do not see in other countries. Healthcare is a critical part of it, but it is not the story of human potential, thriving, and well-being. So today we find ourselves in a mental health crisis that has been overlooked but amplified by COVID. To what extent do we have the ingredients in our narrative that speaks to that holism in health? Now, we're seeing a lot of promise in individual companies, individual communities, as we're studying it at RAND and other places, that there is this window where people are saying, look, the economy should be rooted in a health and well-being frame. In fact, the Treasury Secretary has made these connections. And yet, are we ready to take that opportunity in the next basically 3 or 4 months and say we're going to be bold and grander and not make the conversation small? I think that's a challenge to all of us in terms of narrative. When we talk about political and social will, we've had the privilege at RAND to be conducting a survey that we call the National Survey of Health Attitudes, which is really trying to track mindset and expectations around health and people's appreciation of many of the things that we know drives health, that influences health. And we were doing this before 2020, but in 2020, we took the opportunity and we said, goodness, if there was ever a moment given the conversations about equity in the country, social justice in the country, the pandemic in the country. Now we can ask the questions of Americans, do you see your health being interconnected to each other? Do you appreciate social drivers or determinants of health? Do you appreciate health inequities? Do you understand the role of race in influencing our longstanding systemic and structural issues when it comes to health and well-being? And here's the bright spot. In the late summer of 2020, those numbers started to creep up from where they were in 2015 and 2018 when we were asking the American public about this. But perhaps not surprisingly, started to fall precipitously as we continued the survey in 2021. The question that we have to ask ourselves as health leaders and those who care about health, what did we do differently in 2020 to 2021 to actually keep those numbers up? What did we do fundamentally to talk about the issues of health equity in new ways that could be understood by an American public that understands individualism, that understands sort of American motifs around economic mobility? How did we take that opportunity to tie health into those conversations at the individual and community level? It's immensely addressable, and yet I would argue that our actions, our frameworks, the way that we connect has not been honest about where the American public is and where we need to start from. And so we've got a chance here, but a chance, unfortunately, that requires bold vision. Thirdly, I would sort of say to us, and we're going to be talking, I think, a little bit later about policies and programmatic and structural changes. To what extent, to that question of does it add up, are our systems conversations small? To what extent have they embraced these narrative and political will changes? To what extent conversations that we have about measurement shifts, which have been important, about measuring vital conditions or measuring well-being, or incentive shifts in healthcare, in broader health, in other sectors, has any of it actually made sense in terms of an investment structure paradigm shift for the country? One of the things that we have to ask ourselves is, what are we willing to do as a community, as a field, differently, and not just at the edges, not just in terms of, value-based healthcare, which is important, not just in making sure that we incentivize social determinants of health investing in a community, not just in thinking about health and all policies, all of which are important. But 10 years from now, is that actually going to add up to something fundamentally different? Are we bold enough to say, we're going to give up something as a field in order to get something bigger? What is that we would give up? Do we structure ourselves the same way in city government? I know Dave can speak to this. Should we have a public health department as currently structured? What is fundamentally different that is going to rank health in this country on the order of the gross domestic product? That's actually going to go back to that question of the North Star. What is the health potential of this country? And do we have clarity, vision, and shared value on that? I would submit that all of the systems alignment work, and many of you are doing fabulous work, still doesn't actually fundamentally add up. So we've got an opportunity in narrative and political will, where the American public is, and also in the systems change and shift before, I think, as Dr. T said, the energy sort of slips out of the room, the momentum leaves us. And in every meeting and in every conversation, let's not make the conversation small, let's make it bold and grand. Thanks.
Ooh, that was spicy. I like that. All right, so you're going to go back to your groups that you were in, and you've done introductions. We'd love you to pick up where Anita left off. So as you're having your conversation, what is something outside of the traditional healthcare system that might be an anchor, might be a way of thinking, might change the narrative in a way that captures the momentum before it slips away, I guess, and we have a time frame. The momentum will be gone in 3 months. That's what I just heard. So we now have, we need to be bold, think about the paradigm, and we need to think about that in a way that can make big changes quickly. So that's what we're going to ask you to do. Again, we're going to give you about 10 minutes again. What, if you thought outside of the traditional healthcare system, like what is a narrative that might be able to help change the game for us? All right? Is the task clear? Yeah? All right, go for it. All right, I'm going to bring us back. Paradoxically, it's every facilitator's dream that the people in the room are so invested in their conversation that they stop listening to the facilitator. Like, that's actually a win for us. So, like, the number of times it takes me to get your attention, on the one hand, like, it's maybe frustrating for the people who stopped right away. But I'm just like, it's like a win for me. It's like, oh my gosh, it took us 5 times to get them to stop talking. So that's awesome. All right, so I overheard someone earlier say that they're sort of working on things in their head throughout sort of today and tomorrow, like they're trying to put pieces together for issues going on at home. That is awesome. That's what we want you to do. So hopefully the first keynote has built on, or the second keynote built on the first, your first conversation built on, or your second conversation built on the first, and that brings us to our third. And so we have Dave Choksi. Dave is clinical professor of medicine and public health at NYU Langone Health. And so Dave, kick it off.
Thank you very much, James. I'm really grateful to be in the room with all of you, to be among people that I've learned so much from over a decade as we're here. And more importantly, to be able to learn from all of you over the next day and a half. I have 3 points to contribute to the morning's discussion, but the honest truth is that my co-panelists have covered the ground remarkably well, so I'll be able to keep them quite brief so that we can get back to some of these rich conversations that I know that you're having. So let me dive in. The first point is this. The decline in life expectancy in our country is happening on our watch. I think it's a testament to how this meeting is organized that I'm the first panelist to utter the words, the decline in life expectancy. And that's right, because we should be talking about the underlying forces, what I think of as the tectonic plates of which the decline in life expectancy is one outcome. And with that said, I think we do need to look that in the eye in a way that we feel some responsibility, or perhaps even more, that we feel, a sense of not being good enough, of our not having done enough. It's something that I think should raise the hairs on the back of our necks and maybe send a cold chill down our spine that this is happening on our watch, while we are accountable. I think this is true, and I feel comfortable saying it among colleagues because I know that all of us do care so deeply about the health of our neighbors, of our fellow Americans. And I think part of our charge in feeling that responsibility is in thinking about it a little bit differently and then communicating about it differently as well. One of the ways that I've thought about this is when you look at the health disadvantage, as we know from the NAM reports in the United States compared to other places, what it boils down to is about 16 million birthdays lost every year. We love to jargonize things, especially in public health. This is what we think of as YPLL, years of preventable life lost. But really, this is birthdays lost. These are our grandparents, our children, our aunts and uncles, our neighbors who are not able to live their most fulfilled life because of that health disadvantage. And so I think, what I want to try to express is we need to communicate it in a way that demonstrates both that we feel ownership, but also that empathy. Because I think ultimately those are the things that will keep us from having this same meeting 10 years down the road. And I hope that can also be an organizing frame for us to think about what are the things that we need to set in motion today so that we find another occasion to meet up, but not a similar forum 10 years from now. My second point really builds on some things that Anita said, and it boils down to this. To drive the type of change that we're talking about, we need new narratives. I do want to utter a little bit about the narratives that I think have set us back. It's things like the zero-sum narrative, the idea that for some of us to advance, others must regress. Heather McGhee has written very powerfully about this, and that idea, that zero-sum idea, is at the root of so many racial inequities in our country. Similarly, there are narratives about who is able-bodied, who is deserving, particularly among poor folks in our country, among low-income people. Who is the deserving poor and who is the undeserving poor? Because that defines our resource allocation in the United States, and it has given us excuses that lead to the economic inequities that we see across our country. Of course, these two, the zero-sum narrative and the idea of the deserving poor, these two are linked in the way that they interact in our imaginations and actually result in the policy structures that we see in our world. Forgive me for getting a little bit doctorly, but there's an image that comes to mind when I think about what our task is to displace those narratives. And the image is about naloxone and the opioid receptors that we have in our brain and the central nervous system. So opioids work because they cling to those receptors and they cause a particular sensation, a particular impulse in our brains. Naloxone works because it displaces those opioids. It binds more tightly and therefore displaces the effect that opioids can have. Naloxone, in a way, is even stickier. And so the analogy is, what are the narratives that are even stickier than the zero-sum narrative, than the narrative of able-bodied adults? And this is, to invoke you, James, this is not a rhetorical question. This is our charge, is actually to figure out what those stories are in a way that they spread of their own accord. They actually don't require us to be shouting it from the rooftops because it takes advantage of some of the ways that our brains already work, so that neighbors can share it with their neighbors in the same way that things like the zero-sum narrative have taken hold with such grip in our country. I'm looking forward to hearing others' thoughts about what those narratives should be, and I know that you just spoke in your groups about it. But I did want to put forward one principle that I think those narratives should all adhere to, which is that they have to scramble our existing identity frameworks. They have to challenge the ruts that we have gotten into in terms of how we conceptualize ourselves and the groups that we belong to. Obviously most apparent perhaps in our country in terms of partisan identity, but there are other, sort of deeply seated identities that challenge our ability to have empathy and to connect with our fellow Americans in different ways. One of the thoughts that I've long had, but maybe feel in a different way as a father of a young child, is the identity of being a parent or a grandparent or a caregiver, which I think does scramble some of the other ways in which we conceive of our own identities. in a way that allows us to open up conversations about health policy in a completely different way. What if, the way that we started to talk about any policy was about the effects on children, and to have that be, the organizing frame that then leads to further discussion about what we need to do. I think another displacing narrative is around the American dream and the fact that economic mobility is something that we can all, aspire to, that we can understand, but which, similar to life expectancy, is actually declining in our country. And so the last point that I wanted to contribute will echo some of what Dr. T said in her comments, and it's to remind us that we can do big things. I want to just share the experience that I had with this firsthand, serving as the health commissioner for New York City during the COVID-19 pandemic. And what I saw more than anything, interlaced amidst all of the suffering and the tragedy that I know so many of you also bore witness to, was that false barriers to progress can melt away in the heat of a crisis. We saw this in so many ways over the last 3 years. I saw it when we set up a program to give unconditional cash transfers to our hospitalized patients early on in the pandemic. This was something that we had been incubating before COVID-19, which we thought would require a 5-year timeline, a pilot project, thinking very carefully about the optics of giving our patients, cash. And then COVID-19 happened, and literally overnight, we received a multi-million-dollar grant to be able to give our destitute, sick patients money, which helped to interrupt the vicious cycle that hospitalization can often provoke among low-income people. We saw it in terms of shifting to telehealth, which was a similarly, incremental movement that many of us had been contributing to in healthcare. And then all of a sudden, all of our ambulatory clinicians were taking care of patients in the hospital. And in order to take care of everyone else, we had to shift the entire system to telehealth. This literally happened overnight, and the false barriers to progress melted away. We also saw that it was possible for our government to do big things. You've already heard about, the vaccination campaign. In New York City alone, we vaccinated over 6 million people and saved tens of thousands of lives. But it happened in many other ways, too. I remember in April of 2020, within a span of weeks, we took every single homeless person who was either living on the street or in a shelter, and we put them into a hotel room. And all of a sudden, homelessness, to some degree, changed character, within that very short time frame. So I think it's important for us to to recite these things almost as an incantation, for us to remember, what we are capable of, particularly in rooms like this one, because it helps us both to, have the right imagination to paint the future that all of us care about, but maybe just as importantly, it gets us out of the defensive crouch that I think we so often find ourselves in when we're talking about, health equity, or universal access to care, or reversing the decline in life expectancy. So those are the 3 points that I wanted to make. Again, thank you so much. Thanks to the organizers for setting up the conversation in this way, and I'm looking forward to being in dialogue with you all. Thank you.
All right. Well, I get to stop resisting my desire to hear what's going on in your conversations. I get to give in to that desire. So here's what we're going to do. I want you to take a moment and think. You've heard from our 3 keynoters. What's an idea that's being sparked by what they've discussed so far? So if you're noodling on an idea, like what's something that's coming to you, or a question that you have that would help move an idea forward for you. Maybe that's a question that can be answered by one of the keynoters. Maybe it's a question that can be answered by somebody else in the room. Maybe it's a question that can be answered by someone online. And we may get to that question before we have our final conversation, before our break. We may pick it up later on, but we want to make sure we're hearing either observation, ideas, or questions. So noodle on that for a moment. And then we're going to start in the room, and then we're going to go to Fisher to hear what's going on online. All right, who wants to get started? Yes. I'm doing my Donahue trot. Those of you who are old enough to remember that.
Thank you. Sandy Magnan, Health Partners Institute. I really liked the scrambling our identity, being a parent or a grandparent versus talking about health or healthcare. And saying that we could galvanize around that. One of the actions I put out was let's move the child tax credit forward, get it across the line. What else would people say we could galvanize scrambling our identity around children? What would be other possibilities?
All right, thank you. I'm going to come grab that in a moment. First, I'm going to turn to Fisher. You might want to turn on your mic, Fisher, to let us know what's going on online.
I'm waiting to see if anybody's going to want to come into the room.
Maybe saw something on the Jamboard? Something on the Jamboard that would be useful?
Yeah, here. Maybe, Maggie, could you turn on the screen and we can look at some of the responses to what's happening. I gotta screen share this real quickly. There we go. So
I rarely get to see myself walking away. Okay.
So here's a couple of the responses to Dr. T's initial commentary. And I think what we're ending up with is a lot of just gratitude and agreement to the points that have been coming up. So I've got like 5 things open at the moment. So I don't know if anybody online, do you want to respond to James's question in terms of ideas that have been sparked for you, or there we go, Matt Cross. Matt, can you come off mute? I think we can hear you, Matt, I think.
Can you hear me now?
Oh yeah, cool, there we go.
Wonderful, thank you. So I guess one thing that I'm questioning right now, the previous comment of that decline in health outcome has happened on our watch. We're talking about narrative and how important words are. And does using that phrase, our watch, imply that we have equal decision-making power? And that kind of scares me. Because in working on a lower totem pole in a public health department, sometimes I feel like my decision-making power is very weak. And I would love to make some policy decisions. So I'm wondering about that phrase of our watch.
Good, spicy. Good, thank you.
So a couple other things just came through in chat. So Willett Truelove is asking a question about how do we make that sort of energy that we feel while we're in emergencies more sustainable and frequent? How do we keep that sense of energy available at all times? And then some commentary about mulling the conversation around making the case or persuading others, and how do you both coordinate that maybe and let it emerge? How do you have both at the same time? How do you both try to influence it and pay attention to what is emerging in people's own stories?
Part of what we're going to be talking about this afternoon and tomorrow. Okay, this is unfortunately our last comment before we have our final person who's going to speak with us before we head into our break. So,
Shoma Shaha, We in the World and WIN Network. If moving public will is 99% of the challenge, and we have some clarity around the narratives that need to shift, there's a difference between a narrative or a message and a narrative strategy. And what I don't see is a coordinated field working together to move a strategy forward. And so my my how might we, or big question to all of us, if we are, and we do see that this is happening on our watch, how might we bring our efforts together to flood the zone in a narrative strategy that's intended to both understand what's sticky that can move, where the opposition is, and what needs to happen to create the shifts in positions that help people actually reverse that curve in well-being and life expectancy.
Awesome. Thank you. I'm actually going to have you hand that microphone to the person next to you. Let's give a round of applause for our keynoters. Thank you very much.